All right. Well, hello, everybody. Happy Sunday. We're just having some fun technical issues this evening, so apologies for that. But we still have a wonderful expert, Dr. Ben Szirth from Rutgers in New Jersey, and he is going to give us an incredible presentation. And before he does that, I'm going to go ahead and I'm going to share my screen so you can see a picture of what he looks like since we can't get his video to work. And I'll go ahead and read his introduction. So, are you still there, Ben? Just wanted to make sure.
I just got back on.
Oh, okay.
Yeah, sadly, I got booted off. Okay, your internet connection is on. Great.
Oh, right.
Thank you. Thank you,
So,
Marissa.
I'm going to go ahead and read your introduction here that I have on the screen. So I have known Dr. Ben, as we end up calling him most of the time, for I think, is it 10 or 15 years, or is it longer than that?
15.
Yeah. And it's been really incredible learning from him about the eye and about the different ways to make sure that people's eyes are staying healthy and tracking the changes. And so he has such an amazing story, and here is his very brief introduction. It's that he is the director of Applied Vision Research Laboratory at the New Jersey Medical School and program director for the Ophthalmic Telemedicine Program, a community-based outreach service addressing the homeless and low-income families of New Jersey. His main research interest is in advanced imaging devices that can detect early signs of diabetes, glaucoma, and age-related macular degeneration. He holds 4 patents in the field of ophthalmology and has published over 60 peer-reviewed papers in the area of ocular imaging in English, Japanese, Spanish, and French. Dr. Szirth has lectured in over 25 countries in Hungarian, which is his native language, English, French, Italian, and Japanese. I still think that he could be voted the most interesting man in the world.
Oh gosh, no, I don't think so, but thank you. Thank you for saying that.
I'm just going to pull up I'm going to download the slides again. We had a little bit of difficulty there, so apologies. But Ben, if you want to talk about sort of how you got involved with CWD.
Right. Well, actually, before I start that, I'm going to ask everyone to go and grab a quarter, 25 cents. You're going to need the 25 cents during the lecture. So everybody needs to grab a quarter. It's really important. I won't take it from you, but you can certainly, you'll need it in the next few minutes. The way I started with, this wonderful family is actually I had Jeff, that I met at one of the meetings, and he came over, and I was at a Canon booth, and he told me, hey, I think you should come to our meeting with children with diabetes. And he gave me his business card, and I kind of looked at it and I said, okay. And it wasn't until the very following year, he's really wonderful and persistent, and came back and said, so are you coming? And that's how it started. I first came, I was in the exhibit hall. Then the following year, I brought another physician, and then the following year, and it's been there for, oh my gosh, at least 15 years. Wonderful years.
Yes, and Laura Bilodeau, who has started Friends for Life conferences, just sent a message about remembering meeting you. And it reminded me that I wanted to let everybody that's participating online know that you are very welcome to put in any questions in the chat box. And you can also do questions in the Q&A feature. And if you wish for your question to be anonymous, you can also choose that in the Q&A box.
Great.
And I am pulling up the slides.
It's a large file. I'm sorry for that.
No, it's all right. It's just, go.
Oh, excellent. Perfect. Okay. So if you would go to the next slide, Marissa, please. Great. So everybody needs their quarter. And the reason I wanted all of you to have and hold in your hands the 25 cents with George on there, George Washington, is because the 25 cents is the actual size of the human eye. So we're going to refer to it constantly. And the eye of the president is actually the perfect size that we're going to talk of, the macula fovea, which are responsible for our 20/20 vision. So if you would, hold on to that 25 cents and let's go to the next slide. Thank you. So what does 20/20 vision mean? 20/20 vision means, or 6/6 in Europe or Asia, 20/20 simply means that, next slide, please. Great. At a distance of 20 feet, you're going to have a chart. And if you go to the next slide, please, you're going to see letters of different size, and we call them points. So in this case, 2200 would be the letter E. So 2200 means at 20 feet, your eye can see without glasses a letter that's 200 points in size. And that's really important for us because you'll see how our blood sugar level changes. And when it changes, our vision changes as well. Next slide, please. So 20/20 would be the quote unquote normal. And what does 20/20 mean really? It means that your cornea, the physiological lens, and the retina are in perfect health. That's what it basically means. And if it's not, typically we can wear glasses or corrective lenses and restore some of that vision. But we'll look into those and how vision is affected actually. Next slide, please. There you go. So I'll give you a few pearls as we go along. If you need new pair of glasses or contact lenses, and you wake up in the morning and your blood sugar level for some unknown reason is maybe, I don't know, 250 or 280, well, you will not go, you'll cancel your appointment because you can see the blood glucose level on the far right hand of the slide. As our blood glucose level changes, our vision changes. So that means when you get your glasses ordered, and let's say your blood glucose was 180, well, they're going to give you a correction for 2100. So when you put on your glasses, you'll say, these don't fit. And it's simply because your blood glucose was not where typically it normally is. So try to figure out what your norm is. And if you're close to that norm, you can go for the exam. If you're not, just cancel it because you won't be happy. Next slide, please. Another point that's really super important, and we don't talk about this a lot, and you'll notice that when you come to the screenings in Florida, typically we take your blood pressure, and we take your blood pressure because 1 in 8 deaths worldwide is due to blood pressure issues. And so in diabetes, where I circled the after 9 years, it talks about type 2, but in this case, type 1 is the same. If we can control our blood pressure, and we'll show you examples, but if you can control your blood pressure, you're going to reduce by 34% your risk of having retinopathy. So it's not just the blood glucose level, it's also blood pressure. Let's go to the next slide, please. How much do I have to pay you, Marissa, for doing this?
Nothing at all.
Oh my gosh. So this is what we've learned. The experience we've had, thanks to Friends for Life, CWD, is amazing. We've had 70 medical students that came through the program. Several have stayed in diabetes or associated with diabetes and pediatrics. So we're really, really super happy. But also we've had a lot of experience with manufacturers, companies that have let us use their latest technology that was not available often yet in the US market. So we've learned a lot, and I thank Jeff and Laura for allowing us to bring all these things with us. But typically, the eye exams should happen 5 years after diabetes is onset, or after 15 years old, greater than 15 years old. The newer guidelines from the American Academy of Ophthalmology says 9-year-old or 3 to 5 years post-diagnosis, and that's the American Academy of Ophthalmology. And it says that you need to have a dilated exam. Now, let me tell you what we actually do. Let's go to the next slide, please. There you go. This is what we now know from what we've learned in the past 15 years. We need to have a baseline imaging. That means at least photography of the inside of the eye. And that's what you see on the photograph there. That's the inside of the eye of someone that has type 1 diabetes. She's 23 years old and she's had diabetes since she's 9 years old. Perfectly healthy eye. And so we want to have a photograph of the eye as soon as possible after you've been diagnosed. And why is that? The reason I want to have a photograph is I want to know what did you look like before damage got into the eye, if it's going to happen one day. Otherwise, I'll never know how much time did it take. So I won't be able to say, well, if it took 10 years, it's going to take another 10 years before we're in major trouble. So I like to have a baseline. Insurance companies often won't reimburse, but I'm nearly positive we can talk to the physician and have them do a retinal photograph, and you should keep a copy of that. When you come to Florida, we always try to make copies for you so that you have evidence of how the eye looked like. We do not dilate, especially in people that are below 30 years old. The pupils open up really nicely. There is no need to do dilation. I really don't like to dilate. The dilation doesn't affect the eye. It actually gets into your bloodstream. Your heart goes faster. It just causes too many issues. So I don't like dilation. Retinal photography, as you will see, does not show the main changes, the earliest change. So I do preventative medicine. I want to know what's going to happen before it happens. And that's what we do in Orlando. OCT is a term you'll hear a lot of. And OCT allows you to look behind the photograph that you see there. We can see blood vessels that are not visible otherwise, and no, we don't need to inject you with anything. So no dilation, no injection, just imaging. OCTA, what we've learned is it's the most critical part of our routine eye exam that we should have. Let's go to the next slide, please. So OCTA simply, so erase the gold standard. And this is really what we should have as a standard. Remember, you're the patient, so you need to say what you want. And the more informed you are, the better your outcome is going to be in life. Next slide, please. So ocular coherence tomography and geography, that's what OCTA stands for. So let's go to the next slide, please. So this is what it looks like. So we can see on the photograph, we can see there's a little box on the area that has the photograph of the eye, and that is what's called the macula. Thank you. That's called the macular fovea. Let's go next slide, please. And that is the macula. So if you're looking at your 25 cents, the eye of the president is the area of concern that we have. That's your 20/20 vision. So this is not to scare you, but this is, the more informed you are, the better it is. If ever someone had the misfortune of having a bleed, a hemorrhage over the macular area, the eye of the president, you will lose vision completely for about 90 days. So of course it's unnerving, but as long as you know that, hey, this is temporary, it's not going to last forever, it's because it hit that spot. And that's why we do these exams, because if we can see early changes, we can modify the route that you're going on and change it. Let's go next slide, please. So this is the macular fovea. That's your 20/20 vision. And that's what's so important. When you look at the 25 cents, it's tiny, the eye of the president, and that's what we're looking at. We have to keep that safe so you can keep your vision forever and ever. Next slide, please. And that's your 2020. Next slide, please. So when we talk about glucose roller coaster effect, so this is a photograph of someone, of course, with no dilation, 55 years old or 55 years young, and 20 years of poor control. So I put that in parentheses because I don't like that word poor control. It's just life, so we try to do the best we can. But who has not had this? One day you're 120, the next day you're 190, the next day you're 80, the next day you're 270. So does that really affect the eye? So if you look at the color photograph, you'd say, no, I can't see any change. Let's go one more slide, Marissa. There you go. Can you see the little bubbles? So at 120, it looks fairly okay. At 190, in the center, the dark area, if you can highlight that, the top and bottom of the 190, yep, that area here, and then at the bottom part, those are areas that the bottom photograph, I'm sorry, of the 190, yep, that area. You see, it just popped out. So these are vessels that engorge, and that hole that you have is responsible for your color and black and white vision. So you can see that part of it is actually obstructed. You can't see out of that until you can look at the date. This was captured 8:30. The next photograph is captured 9:25, and you're at 80 when you come and see me. It's now virtually gone. Then you feel, hey, I'm pretty cool. So 11:14, you go up to 270. And that's what, when we talk about the roller coaster effect, that's what we're talking about. Now, it won't happen just that one time, and it has to happen for a long time. The eye is very forgiving. You can mess with it for 5-10 years, not be in perfect control, and then it will make you pay. But so please don't worry, one day you're 190, the other one, no, it's over a long period of time. Next slide, please. And next one, and next one. There you go. So vision changes. So your vision changes with the front part of the eye called the cornea, the lens that's right behind the iris. If it's has a lot of glucose in it, it will get fatter and it will allow you to be out of focus. So if we look at the photographs above the quarter, you'll see 2020 and 2030. And inside the center part where the 2030 is, you'll see there's something, we call it a flying saucer. In ophthalmology, if something looks like a corkscrew or looks like a flying saucer, we're going to call it a flying saucer. And that's the medical term. It's a flying saucer. So fluid is actually building up in there, but you're still in control. Let's look at the next photograph, please. Now here you're at 2200 and you can see the difference. You no longer have a flying saucer. You now have a completely detached fovea. And at this point, the person was out of control, in parentheses, for about 15 years. And his A1Cs were rarely under 14. So it was a difficult thing to deal with. But let's look at the next photograph. And that's what your vision changes. So you'll see the E card, 2020, 2040, 2200, I'm sorry, 100 and 200. So in these cases, when the macula, when we lose that flying saucer appearance, your vision cannot be corrected with glasses. We have to actually go through another procedure. So you're not at the final end here. We can do injections, we can do laser, and we can bring back some of that vision. What's key is that if we have early intervention, we can save you from going to these points. Next slide, please. So again, look at your quarter, look at the eye, and that's what the macula is. So it's tiny, tiny, tiny. And we have to preserve that. And you have two of those, so left and right. And so it's important to save those. Corrective glasses will not fix that. So you need to have a medical intervention at that point. Next slide, please. So if we look at this particular person, blood pressure is 110/70, 6.3, fantastic. Let's look at the next slide. The OCTA is perfect. Below the person now is 130/90, same age. The blood glucose 11, and you can see that that area from the macula that looks like a flying saucer is not as nice as the top photograph. These two individuals have had diabetes for the same amount of years. And we'll talk about the person that's below the 130/90. Next one, please. And this is what's really important. We just published this. One more slide, please. We published this recently in the Journal of Retina. Oops, one back, please. I'm so sorry. Can we go back? Okay, great, thanks. So you'll see on the right hand of your screen, you'll see OCT healthy control and T1DM without diabetic retinopathy. And I want you to look at where it's written 6.3 and 11. And you'll see that the disturbance, one looks like a spider web, perfect spider web, and the other one looks like a spider web that was in the wind. So it's kind of not a perfect setting. And that's what happened when your A1Cs go up for a very long time. Still fixable without having to inject you or anything. And so when you look at the color photograph that the doctor takes in your office, but doesn't have the OCTA technology, they can't see what's happening. And so we're not smart. We just have the perfect tools to predict when damage is going to happen and can we revert it. So let's look at an actual case. This is one of our, so he's 19 years old. He's had diabetes for 15 years. Vision was, this is in July 5th, 2013. Vision was 20/30. Intraocular pressures were 15. Next slide, please. There, his A1C was 12. BG was 421. BP was 130/91. The fact that his father has type 2 diabetes with hypertension really didn't affect anything, but looks good, right? Although the numbers and everything is, you know, high, he still looks good. So remember, the American Academy of Ophthalmology tells you 3 to 5 years without having a review. So you should be good for 3 to 5 years. Let's go to the next slide. So he didn't come there. He didn't come until 2015. And look at what happened to his eyes. So now we have a bunch of hemorrhages inside of the eye. Please don't worry, this is a good story. It comes out really nicely without injections or anything. But what you can see is the graph under the photograph. We can see that suddenly between 213 and 2915, he had a bunch of hemorrhages, but between his blood pressure, the systolic and diastolic, suddenly that's the widest part. So the main reason why he had all these hemorrhages happen is because of his blood pressure. Yes, he has diabetes for a long time. When you have diabetes for a long time, your blood vessels tend to be frail. Think of porcelain. And suddenly when the blood pressure goes really, really high, poof, the blood vessel breaks and starts leaking. And you can see that in the center of the photograph looks like a little flame hemorrhage. So it's a long, elongated area of the hemorrhage between the optic nerve and the macula. And that is typical of flame hemorrhage. So let's go and see one more slide forward. One more, I'm sorry. There. Now, if you look at the bottom photographs, it's really important. Now you can see that the cobweb that we talked about is really nice and set. It's not disturbed. So I know that all what I need to do is get him back in line with his blood pressure, get him back with his BMI, body mass index, get him back in control with his glucose, and I can save this eye without having to do injections or anything. If you look at the color photograph, the retina specialist, the first thing they're going to do is start injecting you. That's painful and very expensive. all what you need to do is understand what's happening inside the eye and what's causing this issue. And this technology is what allows us to say, yes, we can go ahead, or no, this is not a good route. Let's look at the next slide and see what happened. If we could go forward, please. Yep, we'll go forward a couple because you guys did really well. So let's look at the dot hemorrhages. So if we look at dot hemorrhages, that's where your glucose is too high and you start hemorrhaging from blood vessels. Flame hemorrhage is when your blood pressure is too high. And IRMAs is when, for long durations, 15 years. So when you come to me and you say, oh, I've been good, really good for the last year, I know how good you've been. So I'm not Santa Claus, but I know if you've been good or bad just by looking at the inside of your eye. So we know and we can fine tune, but we only know this because of Friends for Life. For the last 15 years, we've studied each and every one that came to see us, and we can predict what's going to happen. And we have algorithms now that is part of what we call deep learning, and it will tell us how you're going to be in the next 1, 2, and 3 years. So let's take a look at the next image, please. Now, take a look at 2014 and take a look at 2016. All what we did is this person actually lived in New Jersey. So I had him come every 2 weeks to the office, and I sat on him and I wouldn't let him off the hook until he did what he had to do, which is simple. Listen to your parents. Oops, I shouldn't have said that. Listen to your parents. Make sure that your glucose is as good as possible, and take your blood pressure medicine. When he came to see me, he said, look, Dr. Ben, all I want is I want you to give me a prescription so I can have one of those handicap things so I can park my car in a handicap zone. I looked at him and said, no, 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 you came to the wrong place. You're going to work. And we got him down in a matter of 6 months. Really, his A1C got way down. His blood glucose was down, his BMI went up, and his blood pressure came down. And that's the example. So let's take a look one more forward. 2015, 2016. Look at that. In literally in 8 months, we had him back in perfect control. And that's what, without Friends for Life, we could have not done this. So if we look at another individual, the retinal images look good. And this is what I'm trying to convey to you. When we say, oh, we're going to take a retinal picture and that's all what you need. No, no. These retinal photographs look perfectly normal for someone that had diabetes for as long as this person has. He's 30 years old. His A1C on a good day was 11, on a bad day was 14 plus. And if you look at the bottom parts now, you can see the macula, the 25 cents. You can see how elevated it is. And, you know, the most fear that most people have in medicine as a patient is death, of course, cancer. The second is losing sight, blindness. So we want to make sure that we can see what's happening, and OCTA is that technology. Let's go one more, please. If we look at that center that looks like the cobweb, you see it's completely out of whack. One more, please. So if we look at this, looks good. Let's look at the OCTA. You can see it's elevated, and the area, the space where we had the spaceship, you can see now that there's a volcano, and the volcano is spewing. That spewing is actually blood that's pushing the retina up. The only thing we can do at this point, and I physically ran after this patient for nearly 6 years, is to do injections, what we call Avastin. Every 3 months you have to come in and we have to do an injection, and then it will return because there's still wiggle room, but it's more painful and you need to take care of it. Next one, please. And one more. So you see, although the color photograph on the 2015 looks really horrible. The inside with the OCTA was perfect, whereas the color photograph on the left shows that the image looks pretty good. Actually, the OCTA is telling you that no, this is a problem. Next slide, please. And I really, really thank you. It's been amazing. And Marissa, I thank you for doing these sessions. I mean, this is my passion in life. And if I can convince someone to do one thing for their eyes, I'm in heaven. So I thank you.
Yes, no, thank you so much. This is Dr. Ben. If you can see my cursor, which I think you can, right in there. And, you know, it's just been amazing having you and having everybody down in Orlando every summer. Personally, I've had some really random things happen. Like I got sand in my eye one year and scratched my cornea, and then I went on a roller coaster and had like a little micro bleed, but it wasn't diabetes related. And I'm just really grateful for you keeping track of all of us, and just helping us keep our eyes healthy.
You know, it's so important, and it's not easy. Diabetes is definitely not easy. And you don't need one more thing. But the last thing I'm going to say on this is the eye is the only part of the body that we can look in without cutting you and looking inside. If you have problems in the eyes, you probably have the problems in your kidneys. So I look at the kidneys and I look at the eyes. When I see a healthy eye, I know you have a healthy kidney.
Yeah, that's a great point. And I think, you know, the other big piece that you talked about was how using the photos instead of using the dilation has been really helpful. And I honestly, I don't think I realized that it's sort of got into your bloodstream. I never really thought about that aspect of it.
You know, sometimes, Marissa, what happens is we forget that our eyes are connected to our body. We kind of not take it for granted, but we kind of forget that they're plugged there. And if your blood pressure goes up, it affects your eyes. If your blood glucose level goes up, your eyes are going to be affected. So everything in your eyes follows actually your body, how your health is.
Yeah, absolutely. And we have a question. So, or actually, it looks like it might just be a comment. So somebody said that after 65 plus a few years, I still have no need for glasses. Blood pressure is in great control and BMI. More than appreciate the presentation. Wow, that's
Oh,
lucky.
it's amazing. It's fantastic to hear when 65 years and you're perfect. Who
Yeah,
can
I've got
complain?
contacts. You can't tell. Um, yes, but I think you're absolutely right. I think it's something that we do sort of not think about as being so connected and integral to our health. And I know for a couple of years, you and I have talked about with my eyes how stress is showing up in my eyes.
Yes.
And, you know, even with relatively well controlled blood sugars and relatively normal blood pressure, I don't know if you have any, I don't, I guess, how does it show up in?
Well, it's such a good question. So stress is one of the things that's going to affect a lot of different parts of your body. But in the eye, the blood vessels become corkscrew in appearance. So think of a corkscrew, and your blood vessels become wiggly. And as they become wiggly, it's because they're under pressure. And with diabetes, if you've had diabetes for a very long time, 65 years, the blood vessels can break and leak. So it's super important to, a word that you might not be familiar with, Marissa, is delegate.
Well, I am a nurse, so yes, I do delegate when I can, but
At
yes,
home, at home.
home maybe not so much. In work, yes.
But you're amazing, because I think of you when I first saw you and we imaged you, and then you were coming back, and then suddenly a few years down the road, you talked about, oh, my husband, my future husband. I said, oh my God, this is fantastic. Then when you said about children, I was like ecstatic, because it's that progression. Nothing can stop you. It's not because you have diabetes. Yes, it's hard, but nothing can stop you.
Correct. And I feel so fortunate that my eyes have been really relatively in good shape, even through pregnancy. Cause I know, I know a few people who with pregnancy, even if they didn't have any retinopathy beforehand, or if they had a little bit, it definitely gets worse during pregnancy due to the extra stress on the body, I'm presuming.
Yes.
That little nugget, a human growing inside of you, no big deal.
But just remember, it's your husband's fault.
Yes. Oh, yes. 100%.
There you go.
And
So
then actually there's a question.
yes,
And this is from someone who I know from California. Hello, Pam. She is asking, are dry eyes common with diabetes?
they're common, period. So it's seasonal. So on the side of the close to the nose bridge, we have small canals. And these small canals, you'll notice that if, for example, you were to cry, suddenly your nose is leaking. Well, that's fluid coming from the outside of the eye, on the cornea. It goes into this canal called Schlemm's canal, and it goes down into your nose. I'm sorry, but it does. So what happens is the Schlemm canal sometimes can block. So and we can clean it out, and we just press. So it's an unkind way of saying this, but imagine if I had a zit on my face.
Right.
You clear out that area, and now suddenly the fluid can flow. In bad cases, we can put a plug in there so the fluid retains, so you don't have dry eyes. But dry eyes in everybody, not just in diabetes, but in everybody that's over probably 60, they're going to experience that. And the best thing is, my best approach is called something called Sustain. It's over the counter, and you can put it up in the morning as you get up. And if you have heat in the house in the east or middle, um, you're going to dry your eyes out, wake up with eyes that you can't see very well. Um, so Sustain is my favorite. You put it in the morning, you put it maybe 3 o'clock. If people around you are smoking, that's another thing, of course. And of course, as we speak of smoking, anyone that smokes will have cataracts before anybody else. But with type 1 diabetes, you could have cataracts 10 years before. Even if you've never been around someone that smokes, you can develop cataract 10 years before. And the key to avoid that is wearing sunglasses. If you wear sunglasses, you will be at the same or better level than anybody else that doesn't have diabetes. So we have to remember, we have something that's called VTD, vision threatening disease. So if you have diabetes, you can also have glaucoma at the same time, and cataracts. And so it's important to check all of those things. A software that we use is, we are now, for the last few years, we've been using artificial intelligence. We download all the images we capture. Artificial intelligence analyzes your images for multiple problems: glaucoma, diabetes, cataracts, and then it tells us what level of disease you might have in the eye. And then we're not just concentrating on the diabetes, we can avoid other vision problems.
Yes, I am always wearing my sunglasses, and I have you to thank for that.
Oh, I'm so proud of you. And I'm so proud of your nursing status. I've been following you on LinkedIn and seeing how you're progressing. I'm really, really so very proud of you.
Yeah. Oh, thank you. I know I did forget to introduce myself at the beginning, but I am really enjoying helping working at CWD as clinical director. I mean, it's really fun to do these kind of things and help make sure everybody has education and access to education related to diabetes, because as you've said a couple times, it's not, just taking a pill or anything. It's complicated. And as we both know.
Not every day is a good day.
Correct. And A
Exactly.
B doesn't always equal C, right? I think
Exactly.
that's one of
Exactly.
the hardest parts. And we have another question from Heidi. So her question is, why do ophthalmologists seem to not do the OCT tests? Because she's only experienced it at Friends for Life.
So she has to come back to Friends for Life. So I'm always in trouble because I present at various meetings,
Oh,
um, and I say it the way it is. So the OCT, the cost of the machine is $75,000.
yeah.
And so somebody has to pay for that. When you go to the eye doctor, according to how we can do billing, we can only billing for one imaging technology.
Okay.
And the standard of care is the gold standard is retinal photography. But Marissa, it falls short 10 years. And the paper we just published now in Retina, uh, I had so much hate mail sent to me because people are literally saying, you're destroying our practice. Well, get with it.
Yeah.
I don't care what your practice is. I care about the patient. So we've been lucky. We've gotten equipment from different companies. Um, you know, Jeff and Laura are amazing to help get all that equipment there and get all the students there. And so, yeah, OCT, most doctors now have OCT. OCT is not enough. We need in diabetes type 1, we need to have OCTA because I don't want anyone to get an injection of fluorescein because it's not necessary. You have a machine that does that. So what happens is I can charge $35 for a regular photograph.
Mhm.
If I do an OCT, I have to have the patient come back the next day and I can only charge $35. So the machine is worth $75,000 plus the technician plus the space.
Right.
So unfortunately, yeah, in this system and the technology that uh, that's referred here, OCTA, we at in Florida, we've had this technology now for 4 years, and it just hit the U.S. market a year and a half ago. So we usually have stuff that other people don't have.
Mhm.
And I have a lot of people from the meeting that goes to see their doctor, and the doctor looks at it and says, I don't know how to interpret this. So please come to the meetings. And
Yeah.
eventually people will have the technology, but it's really important. And what I would suggest, if I may, take the images we give you and show them to your doctor and say, this is how the standard of care is at children with diabetes. And,
Yes.
you know, it people will change. I suggest always people go to a university hospital because typically they have that technology, whereas a private practice may not have that technology.
Yeah, that makes sense. And I think it's just so in line with how CWD feels and we hope to be doing for people with diabetes with learning about the newest latest and greatest technologies with diabetes, and you're doing it for our eyes. And I almost wonder what other specialties we need to bring in so that we can get access to even more technologies. And unfortunately it always comes down to sort of the dollars and cents. I got my quarter.
Oh, you see? Thank
Um,
you.
but hopefully, with seeing how prevention can help people and help prevent further costs later on, maybe one day we'll get things covered more easily.
It's often political, and I'm hoping that things will change in these years. And then with COVID, it's always difficult to
Right.
do your normal visit. We've been able to set up a system where I can remotely operate from anywhere on the planet a machine that's in the clinic. The patient sits at the machine, and I can remotely operate the equipment and capture all the imageries we need. And that's really pretty cool. Um, and,
That's
you know,
incredible.
it is. It really is. And that allows us to, A, keep the patient safe, keep us safe, and have continued care. As I said, we have deep learning now. And if I capture 3 times a patient's eye, then the machine will tell me what the outcome is going to be in the future. So deep learning is really very powerful stuff. Sadly, it's expensive, but it's,
Yes.
we're lucky because we have it. So we want to
Yeah.
share it.
And I feel so lucky to have had you watching over my eyes for all these years.
Well,
Um,
you're doing an amazing job. So we need to make sure your eyes are perfect. I just want to mention something, Marissa. Um, so we've had over 70 of our medical students that came through. And I
mhm,
always tell this story because it's so important. When the students are done for the week, I always sit down with them and I say in a group, I say, so what did you learn?
mhm,
And invariably, one of them will say, what I've learned is that diabetes is not just one person. It comes with a family, with parents, with grandparents, with siblings, with, you know, friends.
mhm.
And they leave with, oh, it's not isolated to that one person or the adjective of, oh yeah, the diabetic patient, like you pointed out. It's, diabetes is a whole group, and that's what they've learned. And as future doctors, that's what they leave with. So it's really powerful.
That is, I think it's the most important part of being a healthcare professional. And as a nurse and a diabetes educator, I usually tell people, listen, I have this degree, I'm a nurse and I'm a diabetes educator, but my first priority is a person with diabetes. And that's really where I speak to people the most because when it comes down to it, we as humans, as we've seen in this past year of social isolation and social distancing, is we really need each other. And there it's amazing that we can use technology like this to stay connected because being human is just an important part of our experience. And I am so excited that the residents and the fellows that come are taking that away, because it's really the most important part.
It is. We had a fellow 2 years ago that came from Taiwan, and she's a vitreoretinal surgeon. And she went back to Taipei, the capital, and she started a screening program for type 1.
Nice.
It didn't exist. How
Wow.
can that be? you know so she came with her kids, and she set up this program. You can go see your eye doctor in Taiwan and they'll screen you, but she has a free type. I said, oh, you stole our concept, but it's good. People come on a Saturday that have type 1, and that's it. They get the whole screening. So the more we can pass that along, the better it's going to be.
Yes, definitely. And there's another question that someone put in the Q&A, and it is there a network or a way to find out what doctors have the OCTA technology, or is it just calling? And I know you mentioned that trying the university physicians' offices could be one way of doing it.
Right. Unfortunately, it's not. There's not a network. I think the doctors don't want to put there because they don't want to shame themselves to. Oh, I don't have the latest tech. But it's really important to target first university hospitals, and then call them and say, do you have this technology? And if you don't, hang up and call the next one. Um, you deserve the best care. I mean, you deal with it all year long. Um, the regular photograph was good 10 years ago, and I'm sorry to say it's way surpassed.
Yeah, and somebody also just mentioned that at the Jules Stein Eye Institute in UCLA, they
Yes,
mention OCTA for glaucoma, but they don't mention it for T1D.
right. But it's as long as you have the machine, they can do it. So probably again, you know, that was our rival. I spent 13 years in Los Angeles at the USC. So they're at UCLA in Westwood, of course, and it's an amazing piece of technology. But probably the glaucoma service paid for the machine, so they talk about that. But all OCTAs can do the front of the eye, the back of the eye, retina, age-related macular degeneration, glaucoma. They're just talking about glaucoma because that's probably who paid for it.
That makes sense. And it's probably, related to the billing they can do for it that will help hopefully cover the cost of the machine for
Right.
them.
And I'm sure there's always negotiation, and
Mhm.
especially if you've been to our meetings in Florida and you have images and you show them and you say, can
Mhm.
you do this? Yeah, they'll do it. They'll do
Yeah.
it.
I think, my question for you, you said you published a paper recently, which I'm going to look up, but I'm wondering is how do we, sort of help push this forward as a standard of care for diabetes?
So for type 1, I'm going to make a precision on here. Um, what we do is every year we go down to Congress and in October, and we have the opportunity of waiting an entire day for 5 minutes, and we sit in the room for 5 minutes, and I talk their ears off for 5 minutes about type 1 and the importance of that. And, you know, the more we can, I did presentations for the ADA.
Mhm.
So I'm trying to have the most people here that will listen to me talk about type 1 and the importance. Too many times, it's frustrating. Too many times people will say, oh, well, type 2, say, yeah,
Right.
type 2. But type 1, you deal with it your entire life. It's not just 20 years of your life, it's your entire life. I'm not putting down type 2, I swear. But type 1 is very complex. And I wish we had another name for that so people don't mistake and say, oh, it's the same as, I had someone that told me recently, oh, all what you need to do is lose a little bit of weight and you'll be fine. Yes, yes. Can I have your pancreas, please?
I know, I know. I like there's a before memes were memes, there were these little cards that people would put on the internet that were pretend, but it was, what kind of or can you have no, what kind of cookies can a person with diabetes not have? And it's like it's cookies or cookies with poison in them. And it's of course we cannot have the cookies with poison in them. But I think it's just a humorous way of the things that we deal with every day as people with diabetes. And it's not to shame any other disease states, because I think again it's personal. We all have our stuff, right? And it just so happens that type 1 diabetes is what we in this space have and deal with. But it gets exhausting sometimes explaining it to people, especially as a nurse, explaining it to fellow healthcare professionals. I'm like, didn't you learn this? Like, but
No,
you
no.
know
The problem is no,
yeah,
they didn't, or they didn't listen. One
right.
of the two.
Well, and
Uh,
it makes me wonder all the nuances about other things that I didn't learn about properly, right? It's
well,
interesting. And being misdiagnosed, we have a couple of presenters at our conference this upcoming weekend, Spring Friends for Life, that are going to talk about being misdiagnosed as type 2, but actually being type 1, and then having some pretty intense DKA episodes and having
mm,
difficulty getting things covered. And it's really complicated.
my hope is I just read recently the what they want to do with our health insurance in the U.S. and I have hope that things will be covered because we should. I mean, it's not something you can put off and say, "Oh, I'll do a test." In no, it's you can't put a price on this. It's your independence, it's your vision, it affects everybody.
Absolutely. Yeah, and I mean, imagine everything's so much more difficult if you lose part of your health, you know.
Absolutely. You know, we have an advantage in Canada. If I may say this, one of our top uh, government person has type 1 diabetes.
Yeah.
And so I went and I was talking about this, and I just saw that she was looking at me like saying, "Well, don't you know?" No, I don't know. It's not written on your face.
No,
But,
yeah.
you know, once we were done chatting, then you have someone that's willing to work with you. And that's, you know, that's good.
Yeah.
In glaucoma, we had someone that was on the Senate that has glaucoma in the US, but we have no one that has type 1.
No, we do have Sonia Sotomayor, who is the Chief Justice,
Right.
right, at the Supreme Court, but she also isn't always very outspoken about it. So I'm
No,
not
no.
totally sure. And I mean, it's hard. She's also, you know, Latina and a woman. So
It's
she's got
difficult.
her,
It's difficult.
yeah,
You know,
yeah, her
we have
platform.
someone, I think, in Vermont or Maine, uh, that the grandchild of this senator has type 1. And I'm not sure if it's Vermont, or I'll have to look it up. But they were supposed to come to Florida. And somehow, I don't know why, but it changed. But yeah, we should reach out and see. But yeah,
Life happens, right?
that's right. That's right. But
We've learned
the,
a
the
lot about that this year.
right. But the message is really, we have to use the best technology we can. And I'm grateful. I mean, the amount of space that's given to us, and the support that's given to us is unbelievable. We couldn't do it, um, you know, without that support. And you know, we are, you know, I'm trying to make sure that people will stay behind and pick up whenever I can't do it, and just continue and continue and continue, because it's super important.
Yes, and if anybody anybody that's listening hasn't been to Friends for Life, we typically gather in Orlando in July because you know that's the best month to go there. But really, because it's you know it's summer vacation for the kiddos. And honestly, it started out we were having conferences just for kids, but really now it's about 50-50 adults with diabetes and kids with diabetes and their family members, and the adults bring you know their children or their significant others, grandparents come, and it's something that's I try to describe it as diabetes camp on steroids. It's a little difficult to describe unless you've been there, but when it's not a pandemic, we tend to have, you know, 2,000, 2,500, sometimes, you know, close to 3,000 people all in Orlando, in a hotel. And Dr. Ben and his team of fellows and other physicians and team, they come down and they have all of their equipment set up in these rooms, and you go and get your retinal screening and your OCTA, and then you get a full explanation of your images and everything right there on site. And then, as Dr. Ben says, you take it back, show it to your doctor, show them what they should be doing, and
Exactly.
let them know that you are getting your eyes checked every year. And it's really an incredible opportunity to have your eyes checked by people who are really experts.
We're passionate. We're all passionate.
Yeah.
Everybody at CWD is passionate. Yeah.
Yes. Well, thank you so much, Ben. I really appreciate you taking the time, and thank you everyone who joined. This will be recorded and put online as well. And I hope that we get to see you. I don't know if we'll get to see you this summer. Maybe it'll be next summer, but
Yeah. There's always a summer.
yes.
Excellent. Marissa, thank you so much for your help and everything you do.
You too. Thank you so much.
Take care.
Bye.
Stay safe.
You too.